Hey team, Sean Everson here. Today we're going to talk about a couple different subjects, but all around the idea of assessment. We're going to split this into a couple parts, and we'll talk about scene assessment and a little bit about scene management. Then we'll progress through to primary assessment and survey and secondary assessment and survey. Each of these broken up into small chunks so that you can review them in the module. All right, let's get started. There's some big changes actually that we're bringing to you with this new 9th edition update of PHTLS. So it was updated and released last year, and so you're receiving the greatest and latest information. Now remember that our primary source is actually going to be the use of the PHTLS 9th edition for our textbook and reference here, but you can also find information, and you do want to review some of the information in Chapter 11, especially to complement the trauma we'll talk about in PHTLS as you take medical classes at the same time. Some specific resources for you to check out in the PHTLS 9th edition. So Chapter 5 and Chapter 6 are where we're spending our time for this set of lectures. And you'll want to reference the trauma assessment algorithm on page 179 of the 9th edition textbook. Also, there's some other resources that I'll reference along the way that are figures, tables, and other resources inside PHTLS. All right, let's get started. So when we talk about doing a scene size up and getting a general impression, some of this information I'm going to put out there is probably not new to you and shouldn't be as an EMT basic, but there are other topics that we'll go through that are probably going to be new to you. So you want to spend some time making sure you know what you have heard before and what you haven't heard before so that you can work on your memorization. All right, so we're going to talk about acronyms as we go through this, but scene size up and general impressions are two different tools we'll use in the progression of a call. The scene size up is essentially trying to gather, before you get in the middle of it, what are the hazards that are presented to you based on this call. The general impression is a general impression not of the scene, but of the actual patient. So that's a big difference. General impression, usually we refer to general impression of life threats, which we'll highlight as an acronym here. So scene size up, scene risks, general impression, what's going on with the patient from a global view. So when we respond to a call, there's a lot of things that we have to take into account. I'm going to speak mostly about trauma here. But as we're responding to that call, we have a lot of things that we have to get done, and they are priorities that we get done. And although they're kind of listed here in bulleted form, there's a lot that goes into each one of these. So according to PHTLS, our first role upon arrival is going to be the overall assessment of the scene. And we want to make sure that first the scene is safe enough for us to respond and other providers to respond, not just EMS, but other responders like fire department, maybe even law enforcement doesn't have a heads up on what's going on. Then we want to try and identify what specific threats are going to prevent us from doing what we want to with our patient. So what puts our patient's life at risk, our life, and in the future, what might impede their success. So if you want to act quickly to, say, deal with bleeding control, but there's a safety aspect of that scene you have to control first, and obviously that's going to stop you from being as quick to deal with that bleeding control as would be otherwise necessary. And as we're going through all of this, we do want to consider critical thinking, because as we're gathering information, we then kind of take it in as data. We perceive it. Okay, what does this mean? What does it mean in context right now on this scene versus the resources that you have or don't have? And as the scene changes, we need to be able to say, okay, now new data is available. Let me revise my plan that I had earlier, and something's changed. Now it's a good opportunity to stop where I'm at and revise again. Now, whether or not we're dealing with scene safety as a means of asking you to regather your thoughts and critical think, or if it's just the fact that the scene's unfolding in just the patient's condition and the scene is relatively safe otherwise. So when we're going through the critical thinking exercises, we want to make sure that we're anticipating things that can come up in the future and preparing ourselves as much as possible for that, so that when it does happen, we're able to respond quickly. Something to remember is that when we are on a scene, planning then and there is not always going to be successful. So a lot of the preparation in responding to emergencies, dealing with unfolding scenes, and even dealing with unfolding patient conditions is practicing that stuff beforehand, communicating with your partner about how, if something were to come up, you and that person would deal with that situation. Very similar to the idea that I'll talk about in class where, if you in Albuquerque, it's probably wise to drive your vehicle around as a responsible gun owner and have a weapon in your vehicle. Again, do so only safely and when you have training. But sometimes I'll ask the class who's doing that, and certainly a few reluctant will share, and I share with them, okay, great, you're on the right path, but do you think that when someone surprises you at a stop sign when you're with your family and totally, jamming out on your Katy Perry and just being a family person off duty, your situational awareness sometimes goes down? If you get surprised by somebody who wants to carjack you, for example, will you be able to safely grab that weapon? Or will you freeze because you weren't prepared for it? Do you know how to exit the vehicle with the weapon that you are thinking about holding? So now, not necessarily criticization of you carrying a weapon in your vehicle, but more to the idea that you'll be more successful if you sat in your vehicle and closed your eyes and think about, how do I get out of this car? Where is the door handle? We need to make sure that the things that are likely to happen on our calls, and there's a whole lot that can happen, we've at least thought about and at best communicated in a practice with our team members. Now, scene safety and scene assessment never actually ends, even when we've left the scene. So that goes to say that our situational awareness needs to be high at all times. And just because we're in the back of our ambulance doesn't actually mean that there isn't a hazard. So we could be at the hospital and walking from the ambulance to a hospital and a hazard presents itself. So it's always on. Our scene assessment, our situational awareness is always on when we're on duty, and really shouldn't turn off until at least we've made it home safe and we're in an environment that we can control. So when we're evaluating patients, a couple things need to kind of be done before others. So when we're just looking at an average call, maybe this is an MCI, maybe it's a one patient call. When we're looking at an average call or an MCI, our priorities are really going to be the same. Our treatment priorities are always going to be first to focus on the things that are threatening loss of life. What will kill our patient first is the old school way of talking about it. Then the next step of priority would be not loss of life. We've got that covered. Now we're looking for things that are presenting the loss of limb. Why is that important? Well, it should be pretty clear that if someone loses a limb, they've changed their life dramatically. If they're used to doing their job with two arms and suddenly they have only one arm because of the accident or the injury that they suffered, now that person's going to have to go through a whole change, which may include them not being able to work in the career that they've almost ready to retire on. So it can be a dramatic change, and not just limbs, but also things like eyesight and just normal functioning capability. And then after loss of life has been mitigated, loss of limb has been mitigated, all other injuries will fall in behind that. Now, asking about an MCI is important too, because you can't really go to an MCI and say, okay, I'm going to look for loss of life and then loss of limb. You're primarily looking to identify in your first organization of MCI triage is trying to figure out how many patients do I have that are at threat of loss of life. And then those are loss of limb. And then those that have all other injuries, or maybe they're within the green or minor category. And then from there, we'll have to figure out what to do. So we need a definition, though, for multiple casualty incident. So a multiple casualty incident means what to you? At your service, or the place that you think you're going to work after graduation, what do you think would be a situation that would overwhelm their resources? Well, if you thought about it, then it kind of depends on where you're at. Now, every agency has its own threshold for an MCI. So our across-the-board definition for MCI is an incident in which the injuries or the patients overwhelm the available resources. So if you're working in an organization that has one ambulance on duty with one crew, and the nearest ambulances are all mutual aid in other counties pretty far away, then your local MCI is probably going to be anything over one critical patient, because taking care of one critical patient will take all of the resources that you have on that one truck without any other resources coming to help you. If you need more patients to be assessed for, maybe you've got a critical and a medium level critical or a minor level critical, you may be able to find ways to work with that. But two critical patients, not going to be able to do with one paramedic in the back of the truck. So an MCI is defined as any situation or a number of patients and injuries that exceeds the readily available resources. Whether we're assessing an MCI or we're assessing one patient at a time, we're going to want to utilize some of our senses and some of our skills in the assessment. So we want to use the skill of observation, and when we're driving onto a scene, say our windshield view, that's primarily the tool you have is observation, looking, inspecting, seeing things, and do so from a distance until you know that it's safe to proceed. Then we're going to take that information in context. What is it that I'm seeing relative to the call that we have, relative to what the outside environment is? And then we need to make sure we communicate that to our team members, to our patients as necessary, and then to other responding agencies. For example, say that we've got a call and multiple agencies are responding or multiple vehicles are responding, and you're first on and you realize that the road is actually a cul-de-sac. There is no actual exit. Well, if you've got all these other apparatus responding to you, the last thing you want to do if you're the first on scene with the rescue or an ambulance is have them all back right behind you so that you can't leave without them having to move their vehicle. So you'll want to communicate. Extra vehicles should maybe go to a staging area, or let them know that they need to stay on one side of the road and keep the egress clear so that you can evacuate as necessary. You never want to be pinned in by another organization. As an example of some of our needs for assessment priorities, the general impression of life threat kind of goes back to that idea of general impressions for patient condition. And once we assess our patient for general impression of life threats, remember we want to try and address any life threats as they come up. Now, there's lots of other reasons to communicate, and so communication has to be clear. So think about what we're talking about and make sure that you've gathered yourself, especially when we have some of those incidents that bring out a lot of the adrenal response to our body. So when we're assessing our patients and when we're assessing the overall scene, our assessment priorities are going to be first to get a general impression of the incident, and that probably means a bit of a general impression of our patient's condition. Then think about the cause and the result of the incident. For terminology from EMT Basic, this is essentially working you through your mechanism of injury. Also, for safety, make sure and observe others at the scene, including people that seem to be on the side of you and the family members, friends. Sometimes bystanders may be on the same side, sometimes they may not. But remember that even people that start off on your side trying to help you, when they get overwhelmed and threatened, their body response is pretty predictable. They're going to become agitated, they're going to be anxious, and that has a high likelihood of violence and other incidents occurring on scene. So although people may start out on a good foot with you, things can dramatically change. So you want to make sure that you're always observing the bystanders and family members. A lot of times we can also separate our team into folks that are hands-on and folks that are hands-off when assessing patients. Let's say that we're assessing a patient and there's a 2-person rescue and a 3-4-person engine on scene. Well, after designating, if you're the team leader, after designating who you want to do vital signs and so on, maybe you choose to stand back a little bit and you've got your chart out and you're making note of the findings that they've made and you're asking questions of the patient. If someone is hands-on, that person shouldn't also be, if we can avoid it, tasked with trying to follow family members and bystanders and make sure that we know where they are, we know what they're doing. That's probably best served for someone who's not doing direct patient care. So if you got somebody else on scene that is there to help you, that's part of your crew, and they don't need to be in the box working with the patient, then you can task them with talking to bystanders, trying to gather information, and just by doing so, the bystanders then see that there's someone they can approach and talk to that isn't who's working on the patient directly. It kind of gives them a bit of a liaison in some ways, and that by itself can mitigate some of the problems when you're trying to, as a provider, give patient care and listen to the family members' needs, and it certainly becomes a very difficult task to do so. So if you can designate your hands-on and hands-off personnel, assuming that you have enough resources, that can be a good way to keep an eye on them. Now, there's a couple of acronyms that are out there, and I find that not everybody has heard these. General impression of life threats, usually most people have heard about at the EMT basic level, and so we'll start there. General impression of life threats is basically your assessment of what are the immediate life threats overall that this patient is experiencing. And that's going to be from a very rapid assessment of both the context of the scene, as I'll call it, so our mechanism of injury, nature of illness, and the very initial findings that we have when we do overall surveys or rapid surveys on our patients and trauma. Now, penman's a little bit different. There's actually a couple different definitions for the acronym that's here. So I'm going to give you a specific acronym definition that we'll utilize in class and hopefully is helpful for you. Most of the penman that I'm referencing here was actually discussed in a pretty good article in GEMS outlining pre-arrival considerations. That's where some of this comes from. All right, so penman. The P in penman stands for PPE, and so we'll talk a little bit about what that PPE is in just a minute, but it's a reminder for you. Before you make engagement with our patient, we want to make sure that we have the appropriate PPE and PPE that you've been trained to use. I want to take note of the environment. That's what the E is for. So not just, what's the weather like, but what's traffic like, what's the immediate environment around the place that I'm going to, and what are hazards that are not weather but environmental, like animal threats and other types of concerns that we have in gaining access to our patients and working with our patients and finally leaving and transporting with them. We want to make note of the number of patients. Often this is going to be hard to gather from certain types of calls to 911 just because the patient isn't necessarily, or the third party that's calling, isn't really that patient with the person that's on the line from dispatch. The 911 dispatcher has a very tough challenge on their hands. So keep an ear open to what number of patients they report. Often it may not be clear to them either, but you're welcome to ask. But when you hear certain situations, you might expect that there will be multiple patients. For example, responding to a rollover that's involving a van. Unknown number of patients is what comes through the radio for your dispatch. If it's a van, though, worst case scenario is that it's chock full of people, and those people will be laying around and overwhelming your resources. So we may or may not have a lot of concrete evidence for this, but as we approach the scene, we can start to clarify this a little bit. Cancel units that we earlier requested that we no longer need, or unfortunately, if you're in this boat a little bit behind the curve, then requesting resources that you didn't request before. The M in penman is for mechanism of injury, nature of illness. So again, taking into account what is the circumstance, what are the things that went into this patient's event. Now, this is where it gets a little funky, the A and the N at the end of penman. The A is for additional resources. That's not usually up for debate. But the difference between additional resources and N, need for additional resources, can be certainly very confusing. The A is all related to us here is for additional resources that are internal. So these are resources that you have access to that aren't out and in another service that we have to call for mutual aid or some other resource. If you have an external additional resource that you need to call, then that's going to be under the last section of penman. And the two of these basically just remind you, think about the resources you need internal, like maybe you need a supervisor to respond, maybe you're a fire department and you're on a rescue, maybe you need an engine to respond. Think of the external resources. Those are often going to be a little bit harder for you to acquire, take more time, and they may be responding from geographically diverse areas not in your jurisdiction. So we want to think of all these things well before we're on scene, because remember, if we can identify a need and get resources responding, that can cut down on the time that our patients may suffer without that resource. And we can always cancel resources after we've requested them and we get on scene and find that they're not needed. But it's much harder generally for us to request a resource. It's going to take a while to get there once we get on scene and realize we're a little bit behind. So let's talk about a couple of these aspects of the penman section. PPE is going to be important. Now, a big part of PPE is knowing how to use the PPE, having the right type of PPE for the job, and then having PPE that not only is right for the job and you know how to use, but is certified and you've been trained on. For example, if you're working on an EMS service and the EMS service doesn't generally stock bunker gear or turnout gear for you, then it'll probably be important that if you need that for extrication, for fire, we need to call someone else who's got that PPE and is trained to use it. In this case, maybe it's going to be a fire engine. So the standard PPE that we use in EMS, regardless of kind of what organization we're with, is going to start with the exam gloves. Now, exam gloves are great for things like bodily fluids, but remember that they're not adequate protection for things like sharp objects, chemicals that could be exposed into an environment, and certainly no temperature, hot or cold, protection is available from them. So when we say gloves, we're generally talking about exam gloves, which are very, very limited. If you want something else, you may have to acquire or look into purchasing gloves that you can use, say, when you're working on a scene for a car accident. You want to make sure that you're not cut. Glasses, goggles, face shields, any of these things that protect our eyes and prevent bodily fluids from entering our mucosal membranes of the eyes and probably the rest of our face are important. These are helpful in a whole lot of situations. Just think about this. If you've got someone at home, like a child that, may see you right after you get off, or you're going to take your clothes off from work and you're going to put them into the hamper and there's other clothes in there. It may be worthwhile, especially if you have little ones at the house or those that are immunocompromised, and wearing a gown, because that will prevent your clothes from carrying the stuff that was lost by the patient or body fluids. Final note here, there's been a change, not too recent, but there's been a change, and there are requirements both from OSHA and the NFPA, whether you're working for EMS, hospital-based, private, or a fire department, you're covered, that require different levels of reflective clothing. Now, when you're on a high-speed roadway, that requires at night or low visibility situations, that does require a Type 3 reflective vest or jacket or some other reflective clothing to make sure that you keep safe. Obviously, there's lots of reasons why that would be unsafe without the reflective clothing. So make sure that you have access to that before you need it. There are other types of PPE, though. These are the types of PPE that generally would require a little bit more training to do. So we have to call not just for the PPE, but for the folks that are trained to use it. As mentioned, the SCBA, or self-contained breathing apparatus, that's what someone might use in a hazmat suit. It's also what would be worn by a firefighter going into a fire in their turnout or bunker gear. Maybe we're doing things like extrication on scene. We may need some more rigid clothing to protect us. That would qualify as PPE. Tactical equipment, that body armor, Kevlar, all those things that we're seeing more and more of utilized in EMS also would qualify as PPE. And by the way, if you're not trained on it, you don't know the qualities, you haven't been fitted for tactical equipment, you may be putting yourself at risk if you just grab some and take it with you to a scene. Confined space and rope rescue equipment often will utilize some of the specialized clothing, and may also utilize self-contained breathing apparatus, hazmat suits, or air that's supplied from a tube from a compressor that's up above ground level, for example. Environmental hazards can be endless, but at the very minimum, we want to make sure that we're taking into account the weather, the temperature, the time of day. When we're responding, what will traffic be like for us to respond? What's traffic like on the scene, and what's traffic like while we're transporting? Crowds, well, when there's a lot of adrenaline involved and we get this kind of crowd mania occurring, it just takes a couple folks that are off the wall to get everyone else excited, and that can cause kind of a crowd or a mob mentality, and that can be directed against you simply because they perceive that you're not working hard or fast enough. Especially in today's world with the use of phones, people are critiquing what we do as public servants more and more. Don't forget about animals as well as an environmental factor. Look for not just an animal, but what are the signs that there's an animal nearby? If you go to a house and nobody's outside to meet you, and you've got obviously a gated fence, and you're trying to get through it, and you notice not a dog, no one's barking yet, but you notice that there's some dog poop in the front yard, or there's toys, or maybe even a doghouse. It's safe to assume there's probably a dog around somewhere. That dog may be inside guarding the owner. So you want to make sure that you take those subtle clues as well before entering. And finally, the environment can also include things like hazards, physical junk around, say, an egress or access route to the house, rickety stairs, all those types of things that just go into our overall, probably our windshield assessment. As defined, our MCI is going to be utilized to describe a situation where the number of patients exceeds the available resources that are there. So when we're dealing with the number of patients in Penman, what we're trying to determine is, do we need additional resources just to transport these folks? So gather more information from dispatch as you can, but realize it may be unknown until you get to the scene. Mechanisms of injury is going to be expanded upon at great detail a little bit later when we start talking about the kinematics of trauma. So that'll be a module following this. And when we're talking about mechanisms of injury, it's kind of all about the idea of determining how did energy from this accident, this injury, translate into the body, and what did it do to the organs. So a good solid understanding of anatomy and physiology is necessary for us then to take our mechanism of injury, what's the energy transmission to the body, and say what's the likelihood, or we'll see in a little bit later, index of suspicion, that it caused an injury. And is that injury likely to be a life threat or a non-life-threatening injury? Especially useful when we're talking about parts of the body or organ systems that we can't directly observe with our assessment techniques externally. As mentioned, our additional resources in the agency is our reminder for A, and N is external resources. So this can include aeromedical evacuation, utilities. Remember, utilities may have an emergency team that responds, but they're not responding code 3. It may take them a while to get their stuff together and go shut off the power, for example. So get those folks rolling early, knowing that they're really external to our organization. The further away someone else is from our organization, both in geographical location and just in the operational setting, they're not emergent responders or first responders, then it's probably going to be even more time for them to respond, as I used an example with utilities. All right, so before we kind of get into some of the phases and look at the stepwise process of moving through a call and getting ready to assess a patient, let's talk a little bit about general impression of life threat again. So we've got our scene survey, that was one aspect, and then now working with patients, the big picture is really what we're trying to focus on. So when we're assessing our patient for our guilt assessment, it may start with us saying, why am I here? Remember, sometimes patients don't always tell us why we're there. They go off into odd tangents about weird situations in their life or who knows what, especially folks that may be calling with the psychological need as well. So we may have to get straight to it. What happened to you? Why am I here? And really what we're trying to do is assess for our global big 3, right? So the nervous system, the respiratory system, the cardiovascular system. And since we're at the advanced level, why don't we add a few more, make it a big 5? We've got respiratory, neuro, and cardiovascular for the big 3. Then we need to make sure that the person's liver is functioning, and we've got renal function as well. Those are the things we're most concerned about. So that could include, like, for instance, an injury causing the patient's kidney to rupture and bleed into their internal retroperitoneal space. It could be assessment of external or internal bleeding. Patients' age, gender, race, and even some of the background information that we may need, like their polypharmacy patients, their older patients, those things are going to help change the likelihood that something happened to that part of their body based on the injury. For example, if somebody's a bit older, it's more likely that lower energy results in larger damage. If they have osteoporosis, it's very likely bones are broken. So those are the things that you're trying to take into account. In the end, you're trying to finally determine if there is an injury, what is it, and can I rectify it right now? How do I fix it, find it, move on? Then is the patient critical, or are they stable enough to make it to the hospital without major interventions? How long do you think this should take when we're talking about the assessment? This really should be within the first few minutes of your patient contact. A lot of this can be done, as I'll talk about in a moment, in your doorway view. So it shouldn't take long at all. In fact, this is something that you should be proficient at doing, even as an EMT basic. Seeing, are there major life threats and can I quickly find them, is a hallmark of our trauma care. Okay, so now we're going to kind of progress through a couple different stages of calls, and we're going to talk a little bit about the considerations that you're going to have before we move on to patient assessment. So when we're talking about the scene phases, or a call phase, generally starts off with an incident. And then after the incident, that something happened, someone has a perception that something's happened, they need to call 911 or activate you in some other means. Dispatch will send out dispatch information and you'll respond. So during the response phase is when we're going to do a lot of our scene preparation, thinking about how you'll want to deploy your resources. What team members do you want to do X, Y, and Z based on the dispatch information? Also thinking about what hazards might I have at this location? Have I been there before? What could be a consideration in this type of call? All of those things are meaning an active thought process while we're responding to the call. So best handled by the person who's not actively driving the vehicle. The windshield view is essentially as soon as you can start seeing the neighborhood or the area that the scene is in, we're going to kind of open up our observation skills and we're going to start very immediately assessing what's around. We want to know a lot about the situation before we walk into it so that we can determine resources and determine our own safety. Once we get through the windshield phase, we're probably getting out of the vehicle, walking up to the patient. Once we can see the patient, so it doesn't necessarily have to be when you talk or touch them, but as soon as you can see them, that starts our doorway view. The doorway view is very specific, has something that I prefer to kind of give you a concise in one block, but this is essentially to try and figure out whether or not the patient is sick or not sick. Do I have to hurry through this, or can we take our time? An important determination that needs to happen as soon as you see the patient. Patient interactions, the next phase, that's where our primary, secondary survey, focused assessment as necessary will occur. Depending on how severe they are, transports occurred. Maybe secondary assessment happens during the transport. After transport, we need to deliver the patient to the facility, so there's some responsibilities there. Again, scene safety always up. And then after we're done, before we go in service to another call, we may have some logistics that we have to take care of, from going code brown all the way through to trying to clean blood up out of the back of the ambulance, replacing life pack batteries that are dead. Before your next call, you still are within the phase of responding from the last call. So situational awareness really doesn't get to turn off for that last call until the next call comes up or we get off duty. So let's go through some of these phases and the things that we want to consider. There's a lot of information here, so I'm going to kind of ramble off just a number of things that we could be thinking about. So once we get dispatch information, the dispatch information should include the location of the incident, as specific and precise as possible, what the nature of the incident is, so this is probably something along the lines of the mechanism of entry or nature of illness. In services that have emergency medical dispatch, that might come with a Clausen code, more on that in a moment. Reported situational issues, like is there a safety hazard, or maybe previously there's been safety issues and this address has been flagged. Looking at number of patients, and then thinking about all the people that are going to be responding with us. So when we're putting all this stuff together, if you don't receive this information from dispatch, you certainly should ask for it, but realize that, again, they may not even have it. But asking for it can help solve some of the problems that we tend to have in responding. So back to communication. When we're talking about the safety of our response and our team's response, there's so much to think about. It all depends on what our mechanism is or what the scene conditions are. But for kind of a general idea, you want to know who else is responding and where they're responding from. Are they responding code 1, code 3? Are they at their station, coming from a longer distance? Do they have some type of capability that you are needing in this case? Sometimes when responders are automatically dispatched, we kind of take that for granted and don't always necessarily understand the capability when someone's on their way. Thinking about the weather conditions and the safety, there's a big need for us to determine weather conditions for our own safety. But if we're responding in a very hot environment, a very cold environment, a patient that's on the pavement, a patient that's laying in water, all of those are going to require our attention in dealing and managing the patient's condition as well. And all will have an influence on their outcome. We're talking about traffic conditions and patterns. Know when there's local sporting events going on, or maybe the local church requires shutting down of the road so that folks can leave during normal mass. Know that schedule. You really need to kind of know the ins and outs of the community you're responding in to be the most effective at determining needs. What's rush hour like in that area? How long is rush hour for? If it's in Albuquerque, apparently rush hour is 24 hours a day, it seems like. Daytime conditions, nighttime conditions. Are you going to be driving into an area where the sun is going to be directly in your line of sight and maybe there's kids roaming around in that area? A high likelihood that we might hit something because of blinding from the sun. Well, perhaps we shouldn't go as aggressive in code 3. So all of this is going to be information that can come at you at different intervals. And so you want to be patient and flexible with the process as much as you can. Some information for us, especially if you're not working in rural areas. It's common in a lot of areas in New Mexico specifically, but across the country in large organizations, in large communities, it's common that there are emergency medical dispatchers that are answering the 911 call. 911 has undergone a change over the last few years, and so we have kind of two versions of 911. One is 911 as we kind of see it in its very basic use, and then there's enhanced 911, which comes with technological enhancements and probably some internal enhancements with the team as well. So if you've been in an agency and you've heard something dispatched like 29 Delta 3, then that's the use of something called emergency medical dispatchers and medical priority dispatch. it's sometimes safe. It's sometimes easy for us to assume that everybody has that. Well, there's communities in New Mexico right now today that have an EMS service nearby and have a dispatch center, but their dispatch center does not do any type of emergency medical dispatching or pre-arrival instructions with patients. In effect, they'll say, okay, they're en route, and hang up on them while they're waiting, or they're a law enforcement dispatcher that has an additional job of dispatching rescue services. In those situations, probably a Clausen code or a medical priority dispatch code is not going to be received. But more importantly, the patients are not going to have any instructions provided by a professional before you arrive. That can make a huge impact on patient care. For example, there was a call I'm aware of a couple of years ago in northern Mexico. The injury occurred in a pretty rural area at an industrial site. I believe it was a crushing injury to a leg with major bleeding. The dispatcher at that time was not trained in emergency medical dispatch services and was not an EMD, and so they took information as they would for most calls, and they dispatched appropriately. All that went well, but then they said, okay, they'll be there soon, and disconnected, did not stay on the line with them, probably for a variety of reasons, and I'm sure no malice is intent here. However, the provider, the EMD, did not spend the time telling the people on scene how to fashion a tourniquet and to put a tourniquet onto the site. Response for the nearest unit was so long that when they arrived, the patient was not resuscitatable because of massive insanguination. And had someone just held a little pressure or put on a makeshift tourniquet, that patient may have survived until rescue services got there. So understanding what's happening before you get there is an important aspect. So determine whether or not pre-arrival instructions have been given, and know what your system and your services are utilizing in their dispatch. And emergency medical dispatcher is actually regulated by the EMS Bureau and is one of the levels that we consider part of the EMT structure of certification and licensure. They're not necessarily a stepwise process, but they do have requirements for initial training and for continuing education as well. Okay, so we've gone through the phase of thinking about what could be going on this scene, and we're gathering as much information as we can, but most of it's third party, if not maybe even more distant, and we're trying to piece these together as we also respond to the call safely. So after we've gone through the response phase and we're now getting close to the location, we're still probably responding. Now we can enter into that phase called the windshield view. So generally this is going to be the view in which you can first see the scene, not necessarily the patient, but you can see the scene. So your general impression of life threats is already going to begin here because you can get a sense of what severity the mechanism of injury is as you start seeing the scene unfold. As we're driving up, though, with the windshield view, we're looking at safety, but we're also thinking about access and egress. Access and egress are kind of opposites of each other. Access is trying to determine what are the obstacles, or what's it like to gain access to the patient. How do I get there? Do I have to be cut out? Do I need to move stuff? Do I have to climb over a wall? Do I have to break through a window? What are the things that are preventing your access? And try to mitigate those as best as possible. So when we drive up to a location, we're looking at these things like what's the pathway to the house look like? Or maybe what's the route walking up to the car that's overturned look like? Could even be as dramatic as the access that I had once while I was in Iraq, where a helicopter went down and we were responding to the event in very low visibility environment. And as we walked in with access, PJs escorted us to the site because there were unexploded ordnance from the helicopter spread throughout the field that we're responding in. And so that access was very specific. The hazards were you stepped left or right outside of the path of the person in front of you, and you may not survive and you may kill others on your team. So it can be very dramatic, or it can be something that's a little bit wider open and less stressful. Egress, the opposite. This is how we move away. This is how we evacuate. Egress, evacuate. So we don't want to think about evacuation when we're on the scene. We don't want to think about evacuation when we have to evacuate. We need to think about it before we get to the scene. So an important aspect of access and egress is to make sure that before we get down and access our patient. We want to make sure that the vehicle is ready to leave as soon as possible. And this is for a few reasons. Obviously, we probably, especially if we have a sick patient, will want to try and avoid obstacles to trying to leave towards the hospital as much as possible. So thinking about which way the ambulance should face. Should it face into the cul-de-sac? Probably not. We should turn it around before we disembark the vehicle to make patient contact, so the vehicle's already pointing in that direction. But it may also need to be an evacuation path if things on the scene go bad. I'll share a quick story with you. I was working in Jemez Pueblo. We responded to a house, a trailer that was a little bit off the road, not too far, but it was down probably 20 feet from the roadway in a very steep driveway. We were driving an ambulance that was pretty old, and as we were responding to the scene of a 30-something-year-old male who's acting erratically, maybe violent, suicidal, maybe on drugs, as we're driving, we request law enforcement. We never get law enforcement actually during the call until after this all unfolds, despite repeated attempts of law enforcement code 3 by dispatch. As we responded and we got into the driveway, the ambulance died. It threw a belt, and so it came to a rest right outside the front door of the trailer we were responding to. There's nothing between the trailer and us, our ambulance, nothing between those two situations. We don't really know what's going on inside the house yet, except it sounds like we shouldn't be there for very long if we want to be safe. So we call for another ambulance, at least for the transport. We get that going. It's a 45-minute response time for them, even if they're code 3. So as we get down, we consider, there's 3 of us, we consider going into the home, and as we make contact with the reporting party and the patient, we quickly realize this scene is not safe for us to be on. There's weapons in the home, including firearms, and the person that's in the home that's acting erratically has made threats to ourselves and to himself. So our options for evacuation are limited, because if we evacuate, that means we run into the woods, probably not a great idea. We run into the ambulance, which isn't going to stop too many bullets. We sit on the other side of the ambulance, which may stop some bullets, but then he just has to walk around the ambulance and find us. And mind you, we're 45 minutes away from EMS responding. No law enforcement's acknowledged responding at this point. So being in that situation left no option for us to evacuate. If you need to evacuate, you want to have as many options as possible. And remember, evacuation doesn't mean we're leaving the patient for good. We're leaving until we can get some scene safety out of this by getting the responder who can help mitigate the threat on scene, and then responding when it's safe enough for us to enter. So always think about, if I have to leave as soon as I get out of this ambulance, how can I best prepare the ambulance for that? Also think about folks that are responding behind you. As mentioned earlier, if I've got an engine company and another rescue responding, and I'm the first one on, but I'm the one that'll have to transport, I need to make sure that they know not to block me in as they go into some of these neighborhoods that don't have great access outward. And again, take the time. Patient's family may be waiting for you and frantic for you to get inside, but it's to help their situation as well, to take the time to position the vehicle as appropriate. If we have multiple patients that we have to manage, you're going to have to prioritize. And sometimes that prioritization might be dictated for you. For example, we've got a patient that we've responded to at a motor vehicle collision, and we'll say that our extrication vehicle is about 10 minutes away. As we arrive, we find the person that is the most injured, that needs to be evacuated the most rapidly, can't be gained access to, and it can't be evacuated until extrication equipment arrives on scene. So then we're left with trying to work with that patient as much as we can across the barrier, whatever that is, and then looking at other patients to determine their needs. Now, once we have access to the patient, then we should focus on the most critical patient. But another example of why maybe we don't have control over the roles that we play with our patients. So anticipation and preparation are going to be our best medicine. Okay, so thinking about safety by itself, there's lots of things that kind of go into this, but we've got pre-incident and incident safety things that we want to consider. Pre-incident safety includes stuff that you do well before there's even a call, and the stuff that we do while we're getting ready to respond to the call. So a good example of things that we do well before we get to the call are taking our recommended vaccinations as a prophylactic approach to make sure that if we're exposed to, in the high likelihood that these diseases, communicable bloodborne diseases will be exposed to us, we want to make sure that we have enough tools in our body to respond. So that's a good form of safety. Training, whether it's training on safety or just training on working within an environment, training with scenarios, with unknown data points and unknown outcomes, stocking the vehicle so that it has everything it needs so we can respond as quickly and safely, and even maintenance on the vehicle, making sure that the tires are inflated appropriately, that our lighting services are working, that the engine's going to run to the scene as we need to. All these things go into playing out our safe scene interactions just as much as our awareness. Once we start responding, we want to try and consider situational awareness, right? So that's being aware of our surroundings and knowing that things can always change at a moment. If we know the scene is not safe, our best protection is to not go into the scene until it's rendered safe. There's lots of reasons why scenes can be unsafe until we have someone else manage it. Take a crime scene, for example. Say we know we're responding to a crime scene, and there's a report that unknown assailants are at large. They may have absconded and left. They don't want to be there when law enforcement gets there. They could be watching so that they can respond, can pounce, can intervene, or maybe they do it as part of their trophy exercise. There's a lot of weird people out there. And so never assume that even with law enforcement on scene, a scene is going to be safe. A scene is just safe enough for us to enter, but can always change at a moment's notice. Another idea is with weapons of mass destruction and terrorist concerns, there's first devices that might be involved in, say, an explosion, and we respond to that. That's the first incident. And then it's well known, well documented, and there have been many, many cases in which secondary devices have been planted with the intent that the first device caused responders to get en route. The second device is delayed until responders are on scene and then blown up so that it can exert maximum damage against the patients or the targets, or maybe against even just first responders as targets themselves. So it's where we least expect it that some of these large vulnerabilities will come up. So anytime you're dealing with something that could be a terrorist incident, you need to have your eyes, ears, and all senses open for secondary devices. Your guard can't go down until you are in an environment that you can control. And with our ambulance and most services, that's not until you get off duty and you get home. Safety measures will go all the way through our training for bloodborne pathogens. Safety measures are going to be incident-specific, patient-specific, and we just kind of think of them as tools. We want to pair the right tool with the right need on a job. Okay, so let's move through to the doorway view. Skipped a couple slides there. I know that you're capable of reviewing. So with the doorway view, you may or may not have heard of this assessment technique. I personally have kind of gleaned this from the pre-hospital emergency pediatric provider course. It's called the Pediatric Assessment Triangle, essentially, but it can be used for adults, and I strongly recommend that you change your practice to incorporate this. So the doorway view's whole goal is to determine, are they sick or not sick? Is this patient critical or not critical? And this is to be done before we talk to and touch our patients. You can talk to them and them not respond and still be able to gather the information that's necessary. So as soon as we can see the patient, we want to make this determination in every single patient we interact with. This should take no more than 30 seconds to a minute to complete, by the way. So right off the bat, as soon as you see a patient, you should know whether they're sick or not sick. So that criteria has got to be pretty vague in some ways because we're just doing it from looking across the room. So the first assessment is the level of consciousness of the patient. In fact, we can kind of see how this stuff comes together. Level of consciousness and the other three components are all basically telling us about the perfusion of the big three organs in the body. So we want to know, is their level of consciousness normal? When I walk in, do they seem to see me approach them? Are they interacting? Are their eyes following me? If I announce myself, do they respond at all? Or are they completely unconscious? Another aspect of the triangle, aside from level of consciousness, is to look at the work of breathing. Work of breathing is going to talk a little bit about the airway, the ventilatory mechanism of the patient's body working, if they're breathing really fast or really slow from your observation across the room, or they're tripoding, or maybe they have signs of cyanosis. All of those things are abnormal findings and can speak to a problem getting oxygen into the body. Then finally, we're going to be assessing the skin color. So level of consciousness, work of breathing, and skin color are our primary assessments. Skin color is telling us a little bit about the perfusion capability of the body that we're assessing. If the person is in shock, for example, we will see them as being pale when we walk in because of the massive vasoconstriction in the periphery that occurs when the body responds to shock. So the rule here is, if any one of these things is not normal, LOC, work of breathing, and skin color, any of them are not normal, not all three of them, you just need one to be not normal, that patient is critical until proven otherwise. So again, we're looking for sick and not sick, load and go, or do I stay and play? So if my patient has a problem with one of those three categories, any problem, not normal, for one of those three categories, then we want to take the approach that our biggest goal is to find life threats and to leave the scene as soon as possible. And we're only going to be doing assessment and treatment on scene in a patient that's sick, as opposed to doing it in the ambulance. We're only going to do it on scene if us intervening on their problem, their life threat, will make it difficult for them to survive to the ambulance. We need a little bit more time to assess, or there's other things that happen on the scene that prevent us from leaving. So we only manage threats on scene, life threats on scene for patients that are sick, if it has to be managed for them to survive to get to the ambulance. That's it. So if you can BVM a patient that eventually needs to be intubated, but BVMing is giving them oxygenation and chest rise and all the good things that we hope from it, then that's what you'll do until you get to the truck. If their airway is failing right in front of you, you'll have to dive into the airway or they may not survive to the truck. That's the essential component of our sick, and our not sick is the opposite. We're not necessarily finding a life threat in our assessment so far, especially at the doorway view. And there could be life threats going on that aren't showing themselves in those three spaces just yet. Every patient's a little different, and their response to these problems is a little bit different. So if we have a patient that has no problems with those three areas of the doorway view, then we assume that they're not having a life threat just yet, but we're going to keep our eyes open, because as soon as we do find a life threat, we fix it and that patient becomes sick and now a load and go. So the only patients that really we stay and play with are those that don't have immediate life threats going on, life, limb, eyesight, or any other process. So when we're dealing with a patient that we're going to stay on scene with, now we get to do a very in-depth assessment just to make sure that other life threats that may be very subtle are not being missed in the process. Now, we'll do this with the patient that we loaded into the truck and hauled butt with, but we're going to do that during transport. If a patient develops a life-threatening condition, or there's some need that you've uncovered in your assessment for the patient to be transported and be qualified as sick, then we immediately change course and we start transporting. Part of our further assessment, though, is not going to be just relying on our observation skills from across the room. Once you start interacting with the patient, we have the opportunity to ask questions, do a physical assessment. The physical assessments we're going to talk about in primary and secondary are all basically to try and determine what are the index suspicions and mechanisms of injury for the organ systems that we're assessing. So as we go through, we want to incorporate a review of systems in our trauma assessment. It may be something that we have to do a little bit later in our secondary assessment to wrap up, but a review of systems is important, because if we find trauma that is impacting, one injury is impacting more than one system, that's the definition of multi-systems trauma. And multi-systems trauma patients are at the highest risk of not surviving our transport or their time in the hospital. So when determining mechanism of injury, that's really the point of everything else that we're doing. As we're looking at the energy transmission to the person's body, and we're going to cover much of this later on, don't worry, we're trying to determine what do I think worst case scenario happened to the organs in the body. Classify the injury as being blunt or penetrating trauma, and sometimes we have a mix of both. And in the end, you want to make sure that you're using it for our index of suspicion to say how sick or how likely is it that this person is suffering something I can't directly assess. How likely is it that they're suffering an injury that has to be rectified by definitive care at the hospital? So there's many things that can go into this qualification. Also, other things about the patient's condition will have to be taken into account as well. A patient that's been struck with blunt force trauma that's 3-year-old versus a patient that's 30-year-old will have two different index of suspicions associated with them based on their body. So again, knowledge of the anatomy and physiology and the normal course of the body doing things, normal, maintenance, healthy, and seeing what happens when an injury changes that is kind of the whole background image of our imagination that has to be useful for a good paramedic to see things that everyone else may miss. When we're working with our index of suspicion, if you haven't played around with this as a specific term necessarily before, I'm sure that as an EMT, you've started to work on this idea. So essentially, when we're looking at the mechanism of injury, we're then going to kind of list what injuries do I anticipate this thing has caused. And we're going to look for certain signs of things that aren't directly observable. So a patient that's been in a motor vehicle collision, unrestrained driver, and it was a head-on collision on a high-speed roadway, if they weren't ejected, then they probably were traveling forward, hit their head on the inside, at the very least, hit their head on the inside of the windshield. Their body probably impacted the steering wheel. So we have the potential that that person, though I may not see signs of it initially, that person may have a head or brain injury, and that eventually will show signs and symptoms, but it may be too late. So we want to try and anticipate as much as possible. We'll find at the paramedic level, anticipation of the outcome of a patient is just as important as finding things that are going on right now. The better you can anticipate how that patient's going to change or develop over time, over your transport time, the better prepared you can be for those developments, and the better you'll be at responding quickly. All right, so as we transition now from our scene safety assessment, we're going to go through our assessment benchmarks. Then the next lesson will be on primary assessment, followed by secondary assessment, and then we're going to move on to specifically assessing and managing patient's airway. All right, so we've talked about Penman, so that's kind of our scene, size up, responding acronym. GILT is going to be our overall life threat assessment when we finally meet our patients. The windshield view is looking at the scene from afar, but as we approach, we're starting to look and gather data on the safety of the scene, on how we want to approach the scene, what our egress and access points are, and so forth. The doorway views right after we get out of the vehicle and we now can see our patient, but we're not necessarily touching them. And from the doorway view, we're going to assess three big areas, right? We're going to assess our level of consciousness, work of breathing, and skin color. If there's a problem there, we're going to have to manage it immediately, find it, fix it, move on. And that's essentially the transition to our initial assessment. So our primary assessment is going to be looking for major life threats, and there is a big change in our primary assessment for PHTLS 9th edition we'll have to talk about. From there, we'll make our priority decision on transport now to transport later, stay and play, load and go. Continuous reassessment is going to occur all the way through until the patient is no longer in our care, and somewhere in the mix, depending on their severity and how busy we are with our basic life threats, the patient's then going to have a focused history, present illness, and looking at things like pertinent positives and negatives and doing a secondary, very thorough assessment. So that's where we've got to move on to next. I'll see you guys in primary assessment.